series. My name is Janet Turan, and I am the director of the Sparkman Center for Global Health here at UAB. And we've been very excited over the past couple of years to be able to start reinitiating sort of pilot funding opportunities for global health projects and to really help people jumpstart some things that they are trying to do in global settings all over the world, and have been very excited that there's been interest in this and people applying in diverse settings from all over the world, different types of health topics, and a lot of really compelling work. So, and of course, we all also recognize that COVID happened and a lot of things have gotten sort of delayed, but on the other hand, it's kind of amazing what has, continued to go on during this time. And so I really want to welcome our presenters who received a pilot grant from the Sparkman Center in 2019, I believe now. And so we have Dr. Brandon Rocque, who is an associate professor in the UAB Division of Pediatric Neurosurgery. And he's been working for several years now, since 2015, on working with neurosurgeons in Vietnam and forming a partnership with them and UAB, looking at issues around pediatric neurosurgical care in Vietnam. So very excited to have him present, and also Dr. Jacob Lepard, who is in his final year of neurosurgical residency training at UAB. And he brings a lot to this because he did an enfolded fellowship in global neurosurgical research and education through the Harvard Program for Global Surgery and Social Change. And he's very interested in international neurosurgical education. So look forward to hearing of them, an update on how their pilot work in Vietnam has gotten started, where they are now, and what their plans are going forward. Thank you.
Thanks, Dr. Tron. I really appreciate the introduction and the opportunity to speak. I've got some slides here. Hopefully they're up and visible now. So first of all, welcome to my home. There's a piano lesson going on downstairs, so you may hear some extraneous background noise, but my part of this should be pretty brief. The main event here is going to be Dr. Lepard speaking, so we'll get right to it. So as Dr. Tron mentioned, we're talking about our partnership with neurosurgeons in Vietnam. Vietnam is a big country with a lot of people and a relatively small number of neurosurgeons. So it's certainly not the most underserved of areas in the world, and the neurosurgeons they have there are very well trained. They're excellent surgeons. There's not a whole lot of pediatric neurosurgeons though. So in general, in the United States, it's about one pediatric neurosurgeon for every 1 million people. In Vietnam right now, there's probably 4, 6, maybe 8 people doing full-time pediatric neurosurgery for their population of about 100 million people. So we started working with them, my senior partner in 2013 and me in 2015. And the goal was really to build a partnership that focused on building the capacity for pediatric neurosurgical care in the way that our Vietnamese partners felt was needed, and really guided entirely by their efforts and what they wanted to do. So we started out at one of the main surgical centers in Ho Chi Minh City, at Children's Hospital number 2, which is this little banner down here. It's one of the largest pediatric surgical centers in the country. It's called number 2 just because it's not number 1, but it's the only center in southern Vietnam that has a neurosurgical presence, at least as of 5 years ago. There's a new center opening now. And then we began working also with several hospitals in Hanoi, including the National Hospital Pediatrics and the National Cancer Hospital. But as we got involved in the project more and more, what they really wanted to develop was a surgical epilepsy program, in addition to all the other things that they were doing in terms of treating but more common pediatric neurosurgical conditions like hydrocephalus and spina bifida. So we spent a lot of effort on helping them build that epilepsy program by collaborating with them in terms of both bringing the personnel who had that expertise to Vietnam, and then bringing their surgeons, their neurologists, their EEG nurses and techs, pathologists, et cetera, all to Birmingham to spend 2 or 3 months as observers here at UAB. And then at the same time that all of this is going on, we've developed an online or an electronic mentorship program that allows us to continue to see patients remotely. We were doing that before COVID. We've kind of amped it up a little bit since COVID. That's allowed us to keep working closely with our partners. And of course, we learn as much from them as they learn from us. So it's really not a missionary surgery kind of model. It's a hand-in-hand building of capacity for their program. One of the things that they have not historically done a lot of, however, is oh, sorry, forgot about this slide. We're doing telecollaboration still. They have not done a lot of research, and so one of the goals of this project was to leverage some of the things that they were doing a lot of and already quite skilled at, and say, okay, how can we help you develop and build a clinical research infrastructure using the resources that you have, and really that's a huge volume of patients, so something that you can quickly learn from. So the proposal that Jacob's going to tell you about is focusing on hydrocephalus and myelomeningocele. What I'm showing you here is a couple of papers that we have published on that epilepsy surgery side of things, where we're building capacity and showing how the outcomes are pretty solid after learning new techniques. But then Jacob's going to tell you about how they've done really taking care of their bread and butter. And it kind of illustrates the model pretty well. The fun part about it for me is that I'm an associate professor and about 7 years into my career, but there's also the education component of this. Not only do I get to work with my partners in Vietnam, but I get to train my residents, like Jacob, to become the trainers. So both teaching Jacob the usual education in neurosurgery. We have a very robust clinical research or clinical outcome science program here at UAB, and our residents are expected to publish and do these projects. But not only that, but Jacob's now also helping us train the neurosurgeons in Vietnam to publish their own work and be their own research experts. So with that, I'm going to give the floor to Dr. Lepard to sum up the Sparkman pilot project. Thank you. We cannot hear you, Dr. Lepard.
There we go. Now, can you both hear me and see my PowerPoint? Fantastic. Okay. Well, thank you for that introduction. And what I'd like to talk to you about basically is just kind of what we've learned over the course of the last few years and with some of the projects that we've been able to do as a result of the Sparkman grant. And so most of that has centered around finding out what's the epidemiology, what is the incidence of hydrocephalus and spina bifida in Southeast Asia, and then what are some options on how to go about treating it, and how are ways that we can improve what's already happening there. And so there's kind of a big background in terms of international hydrocephalus and spina bifida work that we'll kind of talk through briefly. And so this will be the background part. So just for the crowd, what is hydrocephalus? Hydrocephalus in its kind of purest form is, for whatever reason, large ventricles, a buildup of fluid in the head that results in oftentimes increased pressure and in infants worsening brain growth. The setting of hydrocephalus where there's higher pressure and too much fluid in the head is not a good setting for the developing brain. It does not result in normal brain function and normal cognitive outcomes. So that scenario where there's too much fluid in the head can be caused by a variety of clinical situations. And so it's really kind of the end of multiple roads, that being infection or spina bifida, or congenital abnormalities like Dandy-Walker or aqueductal stenosis, or just congenital idiopathic, which basically means we don't have a great idea of what causes it. But there's a lot of kind of rivers that run into that main stream of hydrocephalus. And so in first world countries, United States, Western Europe, the way that is largely treated is with a
Oops, we're not able to hear you, Jacob. I don't know if something. Can
As we
you
were saying, so-
maybe go back
Yeah.
one slide? Yeah, I think the worldwide incidence is where we kind of lost you there.
Got it. Yeah, I can. All right. So looking at what hydrocephalus looks like worldwide, we did a study, I guess about 4 years ago now, looking at what is the incidence of neurosurgical diseases worldwide. And this was based on meta-analysis data. And it's really a bad estimate, to be honest, because what we did is we looked at all studies that looked at published incidences of these diseases worldwide. And we did a meta-analysis to look at by world region, what are the highest reported incidences. And so, as you would expect, sub-Saharan Africa was far and away one of the most common locations for hydrocephalus. And so in sub-Saharan Africa is estimated 180,000 cases, but worldwide is almost 400,000 cases. So looking at where we were focusing on Southeast Asia, Western Pacific region, that totals up to about another 80,000 cases. The interesting thing, though, is if you also look at the availability of neurosurgical expertise, the areas of greatest need for hydrocephalus and most other neurosurgical diseases are where there are the fewest neurosurgeons. Conversely, you look at the numbers for America, US and Canada, there's about 5,000 new cases of hydrocephalus every year, whereas there's more neurosurgeons there virtually than almost anywhere else in the world. So it's an interesting offset. And the question is what to do about that, how to come at that question well. And a lot of the issue right now is simply quantifying the deficit. As I said, this study, it's a meta-analysis and it's a very general estimate, but it still doesn't really get at the specifics of the question at the local level. And so that's at least kind of one thing we wanted to address with our study. A bit more background, options for treatments of hydrocephalus. Most commonly is a ventricular peritoneal shunt. It's basically a man-made tube that goes from the fluid-filled spaces in the brain and just gives the fluid somewhere else to go, essentially. It just runs straight down under the skin, through the chest and into the abdomen, and the fluid just drains into the peritoneal cavity. The nice thing about it is it's been around for decades. People are very familiar with it. It's technically a fairly simple procedure. The downside to it is that these are non-reusable, so you can run out of shunts. They're another expense that oftentimes patients have to pay for, and they fail. They're man-made plumbing, and so they get clogged, they get infected, and so very often children have the shunt and it gets clogged, and they have to come in emergently to the hospital and have their shunt revised. And oftentimes, if they were to not do that, it could be a fatal situation. And so again, in America, where there are ambulances and good roads and easy access to hospitals, that's one scenario. But when you're 5 days away in Sudan, it's quite another. And so because of that, they developed another option for treating hydrocephalus in the low and middle income countries. And it basically involves going in endoscopically with an endoscope into those same fluid-filled spaces and just opening up those spaces some. And that gives the fluid somewhere else to go. There's a lot of theories around exactly how it works. Some people think that it just allows the fluid to egress in a different direction. Others think that there's something to the pulsatility of the flow itself, that by opening up some of those walls, you decrease the pulse amplitude, and that has different effects on the brain. The point is, it's another option for treating hydrocephalus that doesn't involve emergent failures at any point in life. The interesting thing about ETV, that's the name of the procedure, is that they tend to fail in the first 6 to 12 months. And the nice thing about that is most infants don't have a fused skull in the first 12 months of their life, meaning if the ETV fails, the head will just expand and then the parents have time to come in. Whereas once the bones in the skull have fused, if the shunt fails or the ETV fails and there's buildup of pressure, there's nowhere for that expansion to happen. And so it just results in pressure on the brain, if that makes sense. And so So the fact that ETVs tend to fail earlier makes them a safer option for low middle income countries, because that earlier period is the safer period for failure for infants. So centering on that concept, the Cure Hydrocephalus and Spina Bifida Hospital in Uganda has, for the last decade and a half, kind of been a training center, because they do more endoscopy for hydrocephalus really than anywhere else in the world. It's a fascinating place. They have just a very high volume of infants with hydrocephalus. And so what they've turned that facility into is a training center. So surgeons come from all over the world, low middle income countries, and they spend about 2 months there. And during that time, they'll do probably more cases, in that 2-month time span than they will for the next 5 or so years. I mean, it's just very high volume, a lot of great exposure. And so they learn this technique. And so if my slides will advance. And so what the training paradigm consists of is pre-fellowship, that you get screened to make sure that your hospital is one that can support endoscopy, that you have the OR time, availability, the ICU support, et cetera. You come to the Children's Hospital and you spend 2 months there. And then upon return home, you have access to research assistants. You have access to kind of at least every few years visits from the team so that they can check in on you, make sure you're still doing good work. And so you basically learn a decision-making algorithm that, for the sake of time, we won't go into the details of. But suffice to say, there's an algorithm that kind of guides management of using ETV versus VP shunt in these kids. And so the result is, since 2006, 35 surgeons from 22 low middle income countries have been trained, and over 20,000 hydrocephalus operations have been done, which is really a fantastic number. But the question is, they've brought all of these surgeons into Uganda and gone back out. How successfully is the technique transferred? And so that is kind of the question that we sought to look at and answer, and the surrounding information with that. And so the opportunity that I got through the Enfolded Fellowship I was able to do was basically to spend 2 months in Uganda and do a very similar fellowship to what these low middle income country surgeons did, and learn from these Ugandan neurosurgeons who were fantastic neurosurgeons. And then me and my family spent the next 5 months after that in Vietnam with some of the surgeons who had been to Uganda. And so what we did is we worked with their databases. We honestly, it was really more just kind of a boots on the ground look at exactly what life is like there, what practice is like there, other than the 2 to 4 weeks that we're able to spend with them per year. And so it was a great kind of immersion experience. So getting back to that question of how well is the technique transferred, anecdotally, this is a couple of examples. So this is Dr. Lee Quang Mi. He's a young trainee neurosurgeon in southern Vietnam, interested in pediatric neurosurgery, which, as Dr. Rocque mentioned, there's not a lot of pediatric neurosurgeons in Vietnam. So this is him in Uganda performing this endoscopy procedure with one of the Ugandan neurosurgeons supervising him. He went in 2017, and then 2 years later, I was able to go and work with him in Ho Chi Minh City. And so that's me on the bottom picture observing him doing the exact same procedure that he learned in Uganda. And having been to Uganda and then having been to Vietnam, watching him, what he did was near replica of the Ugandan technique. So it was fantastic just to see that that level of fidelity of the technique itself was really interesting. But again, it really comes down to outcomes. What do the outcomes look like? Dr. C is another example. That he's from Hanoi in northern Vietnam, and he's one of our partners. And again, this is him. The top 2 pictures are him in Uganda working with one of the 3D models that they use to teach the technique, and him with Dr. Worf in his office in Uganda. And then the bottom picture, that's again me in the background watching him do the same technique in his home hospital. And so again, how well is the technique transferred? So to answer that question, we used the database that they had been collecting since return from Uganda. And we did a retrospective cohort study looking at all children less than 18 years old with new diagnosis of hydrocephalus undergoing either shunt or ETV CPC. The total number of children we were able to include was 303. We looked at patient demographics, etiology of hydrocephalus, and then the surgical outcomes. The primary outcome was time to treatment failure. So just a bit about the setting. National Hospital of Pediatrics is in northern Vietnam and Hanoi there. They see 40,000 inpatients per year, 350,000 outpatients. They do 6,000 major surgeries, and they have a team of 4 pediatric neurosurgeons, which is unique for that region. They're a very high volume center. So in this study, we had 303 patients, 186 were males, 117 were females. And you can see out of 303 patients, roughly half, he attempted an ETV CPC first. The other roughly half got VP shunt as first procedure. And then as expected, as we discussed, ETVs fail just like shunts do. And so as some of them failed, some of those he did a redo ETV attempt, and some of them he did just a shunt insertion and converted them to shunt. Looking at the etiologies of hydrocephalus, you can see that post-infectious hydrocephalus was about a third, it was 29%. Myelomeningocele was less than 5%, at 3.6. And then kind of the broad category of non-post-infectious hydrocephalus, which includes kind of the whole array of congenital abnormalities, was 37%. And then interestingly, tumor was 30%. So this information alone is interesting because, prior to this study, this information was really just anecdotal. You speak to the Vietnamese neurosurgeons. Yes, we have a lot of post-infectious hydrocephalus. So this alone was fascinating just to put some numbers to this. And for instance, comparing them to Africa, they have still less post-infectious hydrocephalus, but more than a lot of other parts of the world. They have far less myelomeningocele, which is an interesting question in itself, and a lot more tumor-related hydrocephalus, which may be an access to care issue among many other things. And so looking at which of those patients preferentially get endoscopy versus shunt, you can see that the post-infectious children primarily got endoscopy, the non-post-infectious children primarily got shunts, and tumors primarily got shunts. So those were all statistically significant differences just in terms of how he's approaching those patients from ETV to shunt. And then this is one of the most important slides here. This is just the Kaplan-Meier curve looking at endoscopy versus shunt. And so you can see kind of that early drop off as we discussed in the first year or so. And then after that, for the most part, it plateaus. There are some kind of later failures, but over time, over the course of a couple of years, you see this failure curve cross the shunt curve, meaning that over time, more kids with shunts fail than ETVs as the ETV curve plateaus, which bears out with prior studies that we've seen. So that is kind of encouraging because that means at least big picture, he's achieving similar outcomes to Uganda, to other North American series as well. So, again, how well is the technique transferred? This is a first look at suggesting that it's transferred quite well. Again, for the sake of time, I won't delve too far into this, but you can see that children with post-infectious hydrocephalus tend to do worse than non-post-infectious, which is a relationship that bears out with prior studies. And then, broad strokes, older children tend to do better than younger children. And again, that's borne out in data. So this was encouraging just because his outcomes data was consistent with prior studies. It passes the eyeball test, which was encouraging. Let's see. And so then, just kind of thinking about this in terms of points on the map, as I said, we had data from North America. So these are this was a single institutional series. This was a large multi-center series looking at similar Kaplan-Meier curves for ETV outcomes. This was a Ugandan series. And then this was a comparison series that we did in Nigeria. So again, kind of points on the map. But we really had nothing from Southeast Asia to say, how does it compare? Is it more similar to the American experience, more similar to the Ugandan experience? So this is the first study where we've been able to kind of answer that question and kind of look at what are the failure trends and how do they compare to other parts of the world. Similarly, if you look at etiologies of hydrocephalus, we're able to kind of put points on the map now. So you can see post-infectious hydrocephalus is quite the minority in American series. Again, very, less than 7%, 2%. Myelomeningocele is a third in this series and 25% in another. By comparison, in Uganda, post-infectious hydrocephalus is 58%. So it's the majority of patients. Myelomeningocele is 13%. Looking at that same Nigerian series, they had about 26% post-infectious, 25% myelomeningocele. So again, looking at what are the etiologies of hydrocephalus in Vietnam, up until this study, we really didn't have hard data to answer that question. So it's, I thought, quite interesting. So you can see, interestingly, myelomeningocele is less than 5%, it's 4%. And then post-infectious is not as much as Uganda has, but it's certainly more than in high-income countries like the U.S. So it's kind of interesting just to kind of have that spectrum and then be able to say where Vietnam falls on that spectrum, because the etiologies definitely have strong corollary with how the children do long-term in terms of cognitive outcomes. So again, now we've talked about how Dr. C and Dr. Me have done learning the procedure, but then the question becomes, how do they pass that on, and what does that process look like? And that's something that we're really just starting to delve into as well. What are the obstacles? You take a Vietnamese neurosurgeon, you put him in Africa for 8 weeks in the NGO hospital where they do nothing but pediatric hydrocephalus. The hospital centers around pediatric hydrocephalus. And so it's kind of the Disney world of pediatric neurosurgery in the developing world, if you will. You take them and put them back in a local government hospital where oftentimes they're having to kind of argue or advocate for beds, for OR time to do the procedures that they need. They're having to kind of triage hydrocephalus versus tumors versus vascular disease. It's not as simple of a situation as it is in Africa, where 3 times a day you're doing an endoscopy and it just kind of appears in front of you and you've got this whole staff that supports you. So the question is, what happens when they go back and try and practice this skill set? And kind of the more interesting question is, how well do these trainees become the trainers and pass on the skill set to their partners? So we used Dr. C going to Uganda and coming back kind of as the intervention in this study. And the question is, how does his practice change? And then how do his partner's practices change simply by osmosis? And so again, we looked at all children undergoing either ETV or shunt. And we ended up with 743. And the outcomes, again, were time to treatment failure and surgical decision-making. So for the sake of time, I won't go into this table too much, but you can see this is Dr. C here on the left. And again, about half of his patients, he attempted ETV CPC. On the other half, got VP shunt as first procedure. By comparison, his partners, only about 70 out of 440 patients got an endoscopy as first procedure, and the vast majority got VP shunt. So, if you talk about teaching by osmosis, there's certainly there's a lot of obstacles to overcome in terms of deciding to do endoscopy as first procedure versus shunt if you haven't had that intensive 2 months of training. Looking at their actual surgical outcomes, though, is quite interesting, because of the patients who they did decide to do ETV CPC, there was not a significant difference between Dr. C's outcomes and those of his partners. And so my interpretation of that is that the technique itself is transferred quite well. It's something that that can be learned in a short period of time, and you can have good outcomes. What takes far longer to learn is the surgical decision making. And that's true of any surgical procedure in any country in the world. One of my attendings here at UAB says all the time, we could take somebody off the street and teach them in a few weeks to take out a subdural hematoma. But what takes 7 years is whether or not you should, that decision making. And I think similar to that is ETV CPC. You can take someone to Uganda and you can teach them to do a very good endoscopic third ventriculostomy and CPC. But the decision-making of which child needs it, which child doesn't, just requires experience, and it takes a lot longer than 2 months to do. And so I think in separating out the technique itself and the actual outcomes of the technical skills versus the decision-making and the algorithm, you kind of see that split a little bit, the fact that experience and time are just needed. So anyway, again, kind of interesting ways that we were able to kind of tease out this data that we didn't have light on this before. So this was, we thought, quite interesting. And then kind of the last thing that we wanted to look into, and this ended up being a bit of a can of worms that we're still kind of sorting out, is the incidence and risk factors of myelomeningocele in Vietnam. So as you saw on that kind of points on the map slide before, myelomeningocele, which is one of the forms of Spina Bifida, is relatively common in the US, very common in sub-Saharan Africa, and not common at all in Southeast Asia, or at least in Vietnam, as far as we can tell. And so the obvious question there is why? And so that's something we wanted to at least try to look at in our time with the Sparkman grant and my time in Vietnam before that, and ongoing now still. And so what we did is we looked at all the cases of myelomeningocele closure that were from both Hanoi in the north and Ho Chi Minh City in the south. And we did geospatial mapping to see where the children were from in Vietnam. And we mapped where hotspots were of this disease process in Vietnam. So what that gave us is, one, incidence of disease, and then two, we were able to start looking at some of the environmental risk factors for myelomeningocele. So this is what a myelomeningocele looks like, and it's basically a defect in the back of an infant where neural tissue is exposed. So yours and my neural tissue is enclosed by dura, and then bone, and then fat, and then skin, and that's how it was intended. It's well protected and deep inside your body. Children with myelomeningoceles are born with those layers kind of unfolded to where the neural tissue is the most superficial tissue. And that results in damage. And so oftentimes they don't have normal neural function below those spinal levels where that congenital abnormality is. But the surgery to fix it is basically you go and you reclose those layers and you recreate the closure that should have happened in utero. And so in a lot of parts of the world, general surgeons do it, pediatric surgeons, and where available, pediatric neurosurgeons do it. And so we mapped out the incidence of myelomeningocele based on the way that Vietnam is divided up. So there's 63 provinces, 678 districts, and greater than 10,000 wards in Vietnam. And so for all of these children, we had down to the ward that they lived in, which gave us pretty specific geospatial location data for these children. And then the next question you ask is, what environmental risk factors do you want to look at? And so we thought that it would be interesting to look at socioeconomic risk factors, because it's been well shown that nutritional deficiencies contribute to spina bifida, because it's folic acid, is maternal folic acid deficiency that is a strong contributor to the incidence and the development of spina bifida defects in children. Specifically early on in pregnancy, most of the time before most women know that they're pregnant. And so the question we were wanting to kind of look at is, is this not only a disease of poor nutrition, but is it a disease of poverty? Because the two you would think should go hand in hand. And so conveniently, because Vietnam is a communist country, they keep very good data on literacy, under 5 mortality, life expectancy, all of these kind of socioeconomic metrics they have readily available on the internet. Now, that's kind of a two-way street. How reliable are these data that are out, freely available on the internet? It's hard to say, but for the most part, the numbers make sense based on where the poorer parts of the country are. So you can see this map here on the left is one that we created based on where we found the most myelomeningocele cases occurring. Now, it's important to note that these numbers for myelomeningocele are incredibly low. I mean, if you compare to even the rates in the US, these are far lower. And that's even after fortification of folic acid in our normal food supply. And so, again, the question is why, and we'll get at that here in a minute. But you can see, just kind of comparing this map on the left to vegetation. So we looked at an index of vegetation as perhaps a surrogate for availability of nutritional supplementation, green foliage, green vegetation, things that you can get folic acid from. And then we looked at provinces that tend to have a higher poverty rate, which tends to be the northern mountainous regions on the border with China and Laos. And again, looking at regions that had a higher infant mortality rate. These were just a few of the outcomes we looked at. We also looked at percentage of females graduating secondary school, age at first marriage, net migration as kind of a surrogate for conflict. There were a lot of different kind of metrics that we were able to look at with this. And as I mentioned, folic acid deficiency is a known risk factor for myelomeningocele. And so as I said, could poverty play a causative role in nutritional deficiencies? And then what I think is the really interesting question is, if economics becomes a modifiable risk factor for disease, similar to blood pressure, BMI, you say to someone, lose weight, lower your blood pressure, you have a lower risk of heart disease or diabetes. What does that mean from a policy perspective if we can show that poorer regions of countries have a higher risk of congenital abnormalities that then result in higher morbidity, mothers having to be out of the workforce to take care of children with disabilities, et cetera? If economics becomes a modifiable risk factor from a policy standpoint, what do we as a medical community do with that? I think is a fascinating question. I will tell you right now, we have not answered that question in this study, but we've hopefully at least kind of gotten to it some. So these are just some studies looking at socioeconomic status and brain development, just basically to show that there is a precedent in the literature for this discussion. And this is largely in America. There's not good data on this in the developing world, but you would think that the same concepts apply. And just to kind of set up one more question we wanted to answer with this study is the history that specifically America has with the country of Vietnam. So obviously the Vietnam War was several decades ago, but that history is still very relevant on a daily basis there. You think about Southern Vietnam relative to Northern Vietnam, culturally, how they look at the US, there's a lot of differences just walking down the street. There's a museum there that's the Museum of Vietnam War Memorial Museum in Ho Chi Minh City. And one of the exhibits they have there is the Agent Orange aftermath. And so there's an entire exhibit where they show pictures of children with congenital malformations. And so the bottom right here is hydrocephalus. This is a child with spina bifida. Both of these children have spina bifida here in the middle here. This is two patients up top that are conjoined twins. So there's a lot of congenital malformations that the history that the Vietnamese government is attributing to Agent Orange exposure. And so again, if we have geospatial data on where these children are born, and based on historical records, we have geospatial data on where greatest area of exposure of Agent Orange and the missions where those were done, we can compare the two and see if areas of higher exposure of Agent Orange did in fact result decades later in higher congenital abnormalities, specifically myelomeningocele. And the mechanism for that is it's thought that it's still in the soil and still in the water, and so has an effect on spermatogenesis and has an effect on I'm blanking, but it has an effect on in utero development as a result of that. And so there is some scientific precedent for at least how that could happen. But again, is that what happened? And so this is a map looking at areas of the country where there were higher and lower exposures of Agent Orange. And so again, we compared that map, those provinces, to our data. And so just briefly before diving into the results, I found it very difficult to determine the true incidence of myelomeningocele in Vietnam based on the data that we had. And here's why: because the databases that we have were based on two of what are probably the highest volume pediatric neurosurgical centers in Vietnam, Ho Chi Minh City Children's Hospital 2, and then National Hospital of Pediatrics in Hanoi. And so we are basing the fact that the database that we have captures all of the cases of myelomeningocele on what the surgeons there have told us. And so we said, are there lower level hospitals where they're closing myelomeningocele? They said, no, absolutely not. They send them to Hanoi, they send them to Ho Chi Minh City. So we're assuming that that's correct. And so the other assumption is that that you're not seeing a large effect of pregnancy termination in these numbers, because as it turns out, a lot of areas of the world tend to prevent birth with spina bifida and hydrocephalus by screening and termination. And so Vietnam, as it turns out, is very high on this list. They have a very high percentage of mothers who have good prenatal care. So a lot of them get ultrasounds, and that's a very different circumstance than in sub-Saharan Africa. And then the other very different circumstance is that it's very culturally acceptable to simply terminate the pregnancy if there are congenital malformations. And so again, in sub-Saharan Africa, which tends to be much more conservative, that's not the case. And so certainly there's an effect of that kind of political and just social overlay in Southeast Asia and comparing these numbers to sub-Saharan Africa. So what we're really looking at here is a birth incidence rather than a true incidence of disease. And so that is a confounder in these data. But again, looking at the actual environmental predictors, we can see at least some of the trends. So for the myelomeningocele rate, you can see some of these provinces here in the north and then a few in the south are where we found higher rates. for the most part, it's the southern provinces along the coast where the highest amount of dioxin, which is Agent Orange, was sprayed. And so these were two different variables we were able to find: total kilograms of dioxin sprayed, and then percentage of the territory that province sprayed. In neither case was there a significant association between our findings of myelomeningocele rate and then the exposure to dioxin. And then the other measure that we looked at was the NDVI, which is vegetation index. So again, availability of green leafy vegetables, just as part of agriculture there. Is there an association in parts of the country where there are more easy access of vegetation versus less in terms of myelomeningocele? And there actually was an association. So interestingly, in areas where there was more vegetation, there were more myelomeningoceles, which was the opposite of what we would expect. Coming down here, you can see dioxin exposure. There was actually a negative effect, meaning those southern parts of the country where there was more Agent Orange sprayed, we saw, in fact, less myelomeningocele than in other parts of the country. And then looking at least a few of those socioeconomic impact environmental risk factors, we can see literacy rate and annual income per capita were actually positive risk factors, meaning wealthier, more educated parts of the country, we found more myelomeningocele. And again, not only wealthier and more educated, but also more availability of green leafy vegetables, at least by satellite. So again, how do you interpret this data? I think that you have to interpret it in the setting of what we talked about in the last slide, that there's very much a social and political overlay to the birth incidence of myelomeningocele as compared to the true incidence of myelomeningocele. And so perhaps places where there are more education, a higher education level, and more wealth, people are more likely to have prenatal screening that shows a congenital malformation and then decide to keep that child because they can afford to keep the child because they are educated and feel that they can support the child in that sense. And so that's at least one way to interpret that data. And so again, this has ended up being a bit of a can of worms because the question is just so big and so much more than I think what we're able to really answer with this database. But at least looking at some of these socioeconomic risk factors, you kind of begin to see what the trends are, which I think is really fascinating. And we hope will open the door for a lot of better prospective studies and hopefully more broad databases where we don't have to assume that no myelomeningocele are being closed at lower level hospitals. We can also monitor there as well. So this is, I think, step one in a very, very long process of really getting a better handle on what this looks like in Southeast Asia. But, at the beginning of this, we did not know how much hydrocephalus there was in Vietnam, what caused it, how well it was being treated, and then specifically for Spina Bifida, how much of it there was and why there was so little of it. And then again, what were some of the causative factors? And so these are a lot of questions that we were able to come out with this funding, with this project, and it's ended up, as I said, really creating more questions than it's answered. But that's research. And so one last thing that I wanted to just kind of broach into is what we are specifically doing with our Sparkman grant. As Dr. Rocque mentioned, one of the real goals that we had in this process was creating research infrastructure. We don't want to just go and do surgeries and come back. We don't want to just go and do studies and publish them and be done. What we want to leave behind are Vietnamese neurosurgeons who know how to do research, and more important than that, who have a research mentality that allows them to improve their own practice. Every day in the OR, you ask yourself, would this be better than that? And then I think the way that our medical training is here, we naturally then delve into how would I answer that question via a study. Medical training in most of the rest of the world is not that way. And so teaching research really becomes a culture shift. The question that I got very often and most of the places I visited during that travel year were, do you enjoy doing surgery or do you enjoy doing research? Never considering that there's an option to do both and that one could perhaps improve the other and vice versa. And so again, that it really becomes a culture shift. And that is a slow process, I will tell you. But the trend that we have been able to demonstrate in the literature. This is a study by the Boston group that I was able to work with. I'm not on this paper, but I worked with the people who did the study. They did a systematic review of collaborative health partnerships between sub-Saharan Africa and the rest of the world, and looked at where the developing world authors were compared to the high-income authors were. And almost invariably, the high-income country authors were first, second, and last author, and then the contributing partners from sub-Saharan Africa were straight in the middle. And appropriately, that probably reflects what the contributions to the paper was. Hopefully, you hope that. But the question going forward is, how do we get our partners doing more of this, and creating more of their own questions, answering their own questions? And then our goal is really that they only use us for English assistance, and that's it. That's what we want to move towards. And so again, step one in a very long process of that was Dr. C. This is him here presenting his own research, his own clinical outcomes at the Australasian Society of Pediatric Neurosurgery. This was back in 2019. And he did great. English is not his strong point. We worked on his PowerPoint, we worked on his presentation, and he just did a fantastic job. And I think overcoming that hurdle really showed him that he can do that, and he can be on the international forum, which is, I think, what these surgeons need. They do great clinical work, but the next step is getting them shaking hands with other people who do great clinical work and letting them learn from each other from other parts of the world. So that was May 2019. And so coming up with this data, we have Dr. Mee. He got a talk accepted at the International Society for Pediatric Neurosurgery, which is meeting in Singapore, fingers crossed, COVID pending, in November, December of this year. And so we're going to use the Sparkman money to provide funding for him to travel, because that is certainly an obstacle for our partners in other parts of the world to be able to take time off from practice, purchase plane tickets, pay for expensive, meeting registrations, hotels, food, all of that. And so this will give him an opportunity to present his own research instead of us doing that for him, which we're really excited about. Very grateful to the Sparkman Center for supporting us in all of this. And that is all I have. And with a few minutes left, we're happy to talk through any questions y'all have. It was a tour de force of everything that we've thought about hydrocephalus in Vietnam. So hopefully that made sense.
Thank you so much, Dr. Lepard and Dr. Rocque. That's an amazing body of work. And I'm like, it's so fascinating to see all these different aspects that you have kind of delved into. I love this kind of the south to south learning with the Uganda and the other low and middle income countries, people coming there and getting trained in Uganda. That's like, to kind of foster that kind of collaboration, I think is pretty amazing. So I think, I have some questions, but let's see what other questions there. A couple questions here from Dr. Irwin. He says, curious also that historically the more Catholic South had lower rates of MM. I won't be able to pronounce it. You might expect lower rates of termination and thus higher rates of MM. That was an observation that he had. Yeah,
absolutely. And the southern part of Vietnam does tend to have a higher Catholic population. So that very well may be playing a role as well. That's an interesting thought that we hadn't considered.
Mm-hmm. And he also asked, did you see much in the way of cerebral malaria as an infectious cause of hydrocephaly?
So they have looked at malaria, and that is, so there's a whole kind of enigma of what causes post-infectious hydrocephalus in the developing world that I purposefully didn't delve into because it's a talk in itself. But just to briefly mention it, in sub-Saharan Africa, these children show up with radiographic findings of horrible brain infection, and you do the surgery and you test their CSF for virus, for bacteria, and up until recently it has shown absolutely nothing, which has been one of the biggest mysteries of endoscopic management of hydrocephalus in the developing world. What is causing post-infectious hydrocephalus? They are starting to get to the bottom of that in sub-Saharan Africa. They think it's a Panibacillus thymolyticus, I believe, is the species that they're starting to pin it to. That same researcher now is starting to, because of our partnership actually, is beginning to look at the same question in northern Vietnam to get at that. But that researcher is named Steve Schiff, and he's looked at malaria, and interestingly, they've not seen it as a cause. It's a great question, though.
Very interesting. Yeah, I'm just wondering, so what are your next steps now? There's a lot
Yeah.
that you can do, and what are you thinking about going forward?
I think so. There's so many aspects of it. I think step one, we've looked at what are some of the initial surgical outcomes, and in a lot of ways, they're just as good as sub-Saharan Africa and other parts of the world. But in a lot of ways, there's a lot of obstacles. As you saw, Dr. C's partners, for the most part, did shunts on almost every child. And so, the question comes up, what is the obstacle for doing endoscopy for them? So I think using implementation science frameworks, we're going to start looking at what are some of the differences, what are some of the obstacles for implementing this clinical skill set in a government hospital in Vietnam as compared to Uganda, and how can we overcome some of those obstacles and help the teaching of it. That's one. And then I think also we're going to start going through the database, and as I said, just expanding it, because right now there's so many assumptions in what we're looking at. Are these all of the cases of myelomeningocele? Are all of these diagnoses of myelomeningocele truly myelomeningoceles? These are all assumptions that we're kind of making and doing these geospatial analyses. And so I think, the broad sweep at the beginning is useful, and it kind of gives us a direction to walk. But now as we walk that direction, I think getting into some of the details and making sure the data are high quality is going to be really important.
Yeah, I wonder, have any of the other countries who've sent trainees to Uganda looked at outcomes in this way?
Not that many. So that Nigerian series that I mentioned on the points on the map slide, that was the very first one. And that surgeon trained about 10 years ago, so he had quite a bit of experience. And then the Vietnamese database, they have had some of the highest volume outside of Uganda. And so they felt like this would be a good kind of first opportunity to really explore this. So some of the other countries are Indonesia, Myanmar, and there's a surgeon from Nepal, and then several places in sub-Saharan Africa. And so the hope is that they'll accumulate enough numbers to be able to do similar analyses.
That would be really interesting. I was thinking that, in terms in the last topic that you brought about sort of like who terminates pregnancy and who doesn't. I mean, that's all like fascinating stuff that I think could maybe benefit from some qualitative research. Dr.
Yes.
Rocque knows that that's my thing. And I think it would be really interesting to understand how parents make those decisions and, who ends up, going forward and who doesn't, to try to unpack that a bit.
Yeah, absolutely. And I'll tell you, we tried to incorporate some of that into our analysis, looking at, what is the birth incidence of myelomeningocele, and then maybe at the province level or at the district level, getting some number of, what percentage of, so first off, what is the raw number of pregnancy terminations for the province and the district? And then what percentage of those is based on, simply elective versus congenital malformations, and then of those, what are the congenital malformations that are hydrocephalus, spina bifida versus cardiac or something else? And again, even starting to put any numbers to that, it involves so many assumptions. There are some published data on there's a lot of reproductive analyses that are done at the country level for Vietnam that the government does, and so they publish their results, and they include data on number of pregnancy terminations, but they don't go into details on why or where or anything like that. And so broad strokes, we attempted to incorporate some of that into our analyses, but again, I think moving forward, trying to get some sort of higher quality data. It's such a difficult subject, which is the can of worms I alluded to.
Yeah, really.
It's less of a taboo in Vietnam, I'll tell you, than it is in the US, which is interesting.
For sure.
But even still, trying to get real numbers is
yeah.
I think doing, as you suggested, a qualitative study definitely got some possibilities. Obviously, we need the language help and the Vietnamese folks to be really bought into that. This gentleman on the screen that you see here in the bottom right, looking over his glasses, he would be the absolute perfect person to do a qualitative study. He is everywhere in the country. He's the national coordinator for CURE, in Vietnam. He would be just the person to lead that study if we wanted to do that.
That's great. Well, yeah, more
Yeah.
collaboration and capacity building.
Absolutely.
There's one more question here in the chat that I just, it says, is the geospatial data hydrocephalus specific, or is there geospatial data for other neurosurgical conditions like pediatric trauma?
So right now for Vietnam, we only have hydrocephalus. And that's because the database that those surgeons left Uganda with and came back to Vietnam was a hydrocephalus spina bifida database. We're working on building some other databases. Oncology is one, and then trauma is the other, with those same partners to very similar RedCap platform, and just letting them collect that data. And along with clinical outcomes, include location data.
Yeah. Our partners have been very interested in building these databases, and they're piggybacking off of some of the structures that we've created here at UAB, particularly for oncology, which is nice because pediatric oncology requires really specialty care. So there's a lot of referrals to those main hospitals. One of the problems with trauma, to consider where it happens, is that it's not necessarily that specialized. So there may be a lot more trauma care going on at district hospitals as opposed to transfers to the main places where our partners are. So that would probably require a lot more, into the weeds and working with the local doctors, and more than we've been able to do so far. But there is a trauma database, and we are definitely tracking that.
Okay.
And it's a lot of road traffic, a lot of motorbikes in the big cities, and there's definitely work to be done there.
Great. Well, thanks so much to both of you. This is great work, and I'm glad that Sparkman Center could contribute to it in some small way. But we look forward to continuing to hear more and learning how we can collaborate with you to continue some of these efforts. Amazing work. So thank you so much. We really appreciate you talking with us today.
Thank you.
Thanks for the time.
All right. Thank you. Thanks, everyone.